I'm Garrick Stewart from the Center for Advanced Heart Disease at Brigham and Women's Hospital. And today I'll be talking with you about mitral valve disease. I have no relevant disclosures. Let's begin with an overview of the next 45 or so minutes about the mitral valve. First, we'll review the anatomy of the entire mitral valve apparatus, which is important for identifying the cause and potential treatment for mitral valve disease. We'll review the stages of valvular heart disease, which have been emphasized in the most recent valve guidelines from the American Heart Association and American College of Cardiology. We'll distinguish between primary and secondary mitral regurgitation, the treatment of which is very different. We'll talk about the most common cause of primary mitral regurgitation, mitral valve prolapse, which has a wide spectrum of clinical presentations. We'll then move on to mitral stenosis, or narrowing of the mitral valve, which is most commonly caused by rheumatic heart disease. Now, the mitral valve is on the left side of the heart and separates the left atrium from the left ventricle. It has 5 different components: an anterior and posterior leaflet, as well as a rim called an annulus that's made up of fibrous tissue that supports the valve. Below the leaflets and the annulus are the chordae tendineae, which are fibrin strands connecting the leaflets to the papillary muscles. There's a lateral and medial papillary muscle, which in turn connects the mitral valve to the adjacent left ventricular myocardium. Each of those 5 components is part of the mitral valve apparatus. With that anatomy of the valve, it's important to emphasize the stages of progression of valvular heart disease. Now, these stages apply to all valvular heart disease, not just the mitral valve, but it's a good framework for having a conversation about valve problems. Stage A are patients at risk for developing valvular heart disease. Stage B have progressive, mild, or moderate stenosis or regurgitation of a valve, but are asymptomatic. Stage C patients have severe valvular dysfunction, but remain asymptomatic. Stage C1 are asymptomatic patients where the right or left ventricle remains compensated, whereas stage C2 are asymptomatic patients with decompensation of the ventricle. And then those patients in stage D are both symptomatic as well as with severe valvular dysfunction. And so there are 2 types of mitral regurgitation. There's primary mitral regurgitation, which is a valve problem, and secondary mitral regurgitation, which is a ventricular problem. So primary problems with the valve involve the leaflets, the annulus, the chordae, or occasionally the papillary muscles, whereas secondary problems are really ventricular problems, where the geometry of the ventricle has changed, where there's tethering of the posterior papillary muscle. Primary valve problems include myxomatous degeneration or mitral valve prolapse, infections of the valve like endocarditis, traumatic rupture of the valve, non-infectious endocarditis like Liebman-Sachs endocarditis and lupus, or even rheumatic heart disease. Whereas secondary mitral regurgitation can be caused by ischemic or dilated cardiomyopathies, or even hypertrophic cardiomyopathy with LV outflow tract obstruction. Let's first turn our attention to primary or valvular mitral regurgitation. If we think about the stages of primary regurgitation now, stage A patients might have a mild prolapse of the mitral valve leaflet from the left into the left ventricle into the left atrium. There might be some leaflet thickening or restriction, but there's not a big jet of mitral regurgitation. And in turn, because of that, there are no hemodynamic consequences or symptoms. Whereas stage B progressive mitral regurgitation patients have more significant structural disease with more prolapse or leaflet thickening, but with a jet of regurgitation that does not meet criteria to be severe. Sometimes, as the valve leak worsens, there can be left atrial enlargement, but the left ventricle remains compensated. Whereas in stage C, there is severe regurgitation with loss of coaptation or severe leaflet thickening and retraction leading to central regurgitation. There can be vegetations from endocarditis or radiation injury to the valve. And importantly, on echo, these patients meet the criteria for severe MR that include a jet filling 40% of the left atrium or a holosystolic eccentric jet, a vena contracta of 7 millimeters or more, a regurgitant volume more than 60 milliliters, or a fraction more than 50%. These patients almost universally have significant left atrial enlargement because of the regurgitation back into the thin-walled left atrium, and very often have left ventricular enlargement because of the chronic elevation in preload. That back pressure into the left atrium can lead to pulmonary hypertension, and over time, the left heart can begin to decompensate. And when it does, symptoms typically develop. When there's severe stage D valvular heart disease, there is dramatic prolapse, loss of central coaptation, or severe anatomic abnormalities of the valve leading to echo criteria that meet those consistent with severe regurgitation. There's almost universally left ventricular enlargement and pulmonary hypertension, accompanied by a decreased effort level and exertional dyspnea and fatigue. Acute severe mitral regurgitation should be distinguished from chronic severe mitral regurgitation. In acute MR, there's a medical and surgical emergency where there's a sudden regurgitation into the non-compliant left atrium that leads to a dramatic rise in pressure and pulmonary edema. In turn, the stroke volume is all going backwards instead of forwards, which leads to hypotension and shock. Because the pressure is so high in the left atrium, there's often not a murmur, and it's striking that half of patients with acute severe MR may have no murmur at the bedside, yet can appear critically ill. Because of the acute pulmonary edema, it's often confused with a pulmonary process, so an early echo is critical to identify this and distinguish it from other forms of pulmonary edema. Typical etiologies can include papillary muscle rupture or displacement with myocardial infarction, chordal rupture from infection or mitral valve prolapse that can lead to flail mitral leaflet as seen in this echocardiogram, where the leaflet of the valve does not close at the annulus but continues into the left atrium. Patients must be stabilized, and then mitral valve surgery is almost universally indicated if the patient can have an operation. We use vasodilators to improve forward cardiac output and inotropes to support the stroke volume and blood pressure. An intra-aortic balloon pump can reduce the regurgitant volume and LV end diastolic pressure as well, provided there's not concurrent aortic regurgitation. And we use diuretics to reduce pulmonary edema to temporize patients and prepare them for definitive mitral valve surgery. Now, in contrast to the acute presentation of acute mitral regurgitation, chronic primary mitral regurgitation often has a very long latent phase between stage C and D. Patients can have compensated severe regurgitation for many years before clinical symptoms or cardiac remodeling develops. But chronic mitral regurgitation inevitably leads to enlargement of the left heart chambers, including the atrium and the ventricle. Left ventricular filling and stroke volume are augmented with chronic MR, which leads, under normal circumstances, to a hypercontractile ventricle. And so an ejection fraction that tends to be either normal or actually increased with chronic severe MR. And so even modest reductions in ejection fraction, such as below 60%, actually reflect significant clinical dysfunction of the ventricle. That transition from compensated chronic MR to decompensated chronic MR, in addition to be marked by greater left ventricular size and a reduction in function, leads to greater wall stress and greater preload on the myofibers that inevitably leads to decompensation, both clinically and can lead to increased surgical risk. Now, these are the guideline recommendations for the diagnosis and follow-up of chronic primary mitral regurgitation. In all of these guideline tables, the class of recommendation is listed first, class 1, which is the strong base of evidence, class 2, a little bit greater strength, a less intense recommendation, and then class 3, where it's actually not recommended. So the class 1 recommendations for chronic primary mitral regurgitation are that echo is indicated to evaluate the left and right heart size and to determine the nature of the primary mitral regurgitation. If images are not good quality on an echo, it's reasonable to consider a cardiac magnetic resonance study to look at the heart size and MR severity. By the same token, for operative planning, transesophageal echocardiogram is often recommended to delineate the mitral valve anatomy and in turn the surgical approach. Class 2A recommendations are notable for using exercise hemodynamics if there is discordance between the images and the clinical symptoms of a patient with mitral regurgitation. In addition to exercise testing, we can use cardiac catheterization to better outline the hemodynamic disturbance of the valve and determine if the timing is right for surgery. Now, to review the echocardiographic findings consistent with severe primary mitral regurgitation, so that would be stage C or D mitral regurgitation. Qualitatively, if the vena contracta, the Doppler jet in the middle, is more than 7 millimeters wide, that tends to be severe. If the jet encompasses more than 40% of the atrial area, or if there's a wall impinging jet, such as is shown here, that's swirling around the left atria, that's all consistent with severe MR. If there's systolic flow reversal, where the jet actually goes back into the pulmonary veins and back into the pulmonary vasculature, that's also seen in severe MR. Now, if we quantify the amount of regurgitation, if the regurgitant volume is more than 60 milliliters, the regurgitant fraction is more than 50%, so that is the regurgitation volume is more than half the stroke volume, or if the effective regurgitant orifice is more than 0.4 centimeters squared, that's all consistent with severe primary mitral regurgitation. Now, these are the recommendations for medical therapy for primary mitral regurgitation. You'll note that there isn't a class 1 recommendation. However, medical therapy for systolic dysfunction is reasonable, a class 2A recommendation in symptomatic patients who have evidence of ventricular remodeling with an EF less than 60%. Remember, with severe MR, a normal heart should function greater than 60%, and anything less than that can actually represent compromise. And of note, vasodilator therapy is not indicated for chronic mitral regurgitation in normotensive asymptomatic patients. You can use them to treat hypertension, or you can use them to temporize symptom, but in asymptomatic patients, there's actually no benefit, and that's been shown in clinical trials. Now, the most common cause of significant mitral regurgitation leading to surgery is mitral valve prolapse. Mitral valve prolapse is exceedingly common, affecting around 2% of the population, and has a wide clinical spectrum of presentation, anywhere from an asymptomatic murmur picked up by a primary care doctor to a chordal rupture or flail leaflet from chronic mitral valve prolapse and strain on the valve. This can typically lead to myxomatous degeneration of the valve, which sometimes is called floppy valve syndrome. There can be degeneration and thickening of the valve with prolapse and regurgitation, and eventual rupture that leads to a flail leaflet. This can actually be a heritable valve disorder in Marfan or Ehlers-Danlos syndrome, disorders of connective tissue and collagen integrity. It's also sometimes referred to as systolic click murmur syndrome, because that's exactly what you hear. You hear a systolic click which is the valve prolapsing followed by a murmur of regurgitation. There can be chordal elongation and annular dilatation, which can lead to an inexorable cycle of mitral regurgitation, begetting further mitral regurgitation. And mitral valve prolapse is the leading cause of severe MR that requires surgery in North America. In addition to the valve problems, there are a number of symptoms that have been associated with mitral valve prolapse, even independent of the severity of regurgitation. Those other symptoms and signs can include palpitations, atypical chest pain, as well as migraine headaches. We use echocardiography to diagnose and follow patients with mitral valve prolapse. Mitral valve prolapse is defined by the systolic displacement of more than 2 millimeters of the mitral valve leaflet into the left atrium above the plane of the annulus. This is an example of bileaflet prolapse where the posterior leaflet and anterior leaflet are prolapsing, in this case 5 millimeters, past the mitral annular plane from the left ventricle into the left atrium. And if we put color Doppler on such patients, there can be fairly eccentric jets of mitral regurgitation seen. If mitral regurgitation is only mild to moderate, consistent with stage B valve disease, serial echocardiography is typically recommended every 3 to 5 years for all patients with mitral valve prolapse, and a screening echo is recommended for all first-degree relatives of patients with mitral valve prolapse, because this can be familial even in the absence of a hereditary syndrome like Ehlers-Danlos. This is an example of a prolapsed posterior leaflet on a 3D echocardiogram from the perspective of the left atrium. This leaflet is bulging backwards and can cause, by reflection, a jet of anterior regurgitation that bounces off the posterior leaflet and is directed anteriorly within the atrium. When there is mitral valve prolapse and stage D valve disease, mitral valve repair is favored over replacement because of superior outcomes. Now, this is the normal mitral leaflet anatomy from the perspective of the left atrium. There's an anterior leaflet and a thin, almost semi-lunar posterior leaflet. This is what happens when there's posterior flail with chordal rupture and significant regurgitation results. That flail posterior component can be excised by the surgeons, cinched up, and then there's often an annuloplasty ring to buttress that annulus, which has usually seen a lot of enlargement and remodeling over time. Outcomes in experienced centers are dramatically more favorable for mitral valve repair than replacement in mitral valve prolapse with regurgitation. So who should we take to surgery with chronic primary mitral regurgitation? Well, surgery is recommended for all stage D symptomatic patients with severe MR, provided the EF's more than 30. It's actually also recommended for asymptomatic patients with severe MR and evolving LV dysfunction, again, even without symptoms. That's stage C2 valve disease. Mitral repair is recommended in preference to replacement when there's severe primary MR restricted to the posterior leaflet, and repair is recommended when both leaflets are involved or there's anterior leaflet involvement, provided that a repair can be accomplished. And concomitant mitral valve repair or replacement is indicated in patients with chronic severe primary MR undergoing other cardiac surgery. For example, a patient who needs a bypass operation and happens to have mitral valve prolapse with regurgitation should get it fixed at the time of the bypass. Now, I've talked exclusively about surgical options for primary mitral valve disease, but there are an increasingly large number of percutaneous devices that are in development in both early and late stage clinical trials for the treatment of mitral valve disease. The one that's in most widespread use at present is the mitral clip, which is a transcatheter edge-to-edge clip for the mitral valve that mimics the Alfieri surgical stitch, whereby the redundant prolapsing leaflets are cinched together in the middle to create a double orifice mitral valve and dramatically reduce the amount of mitral regurgitation. That can in turn stimulate reverse remodeling and preservation of ventricular function and reduction in the risk of both heart failure and arrhythmia. The clip was evaluated in the Everest 2 randomized trial, which randomized patients in a 2-to-1 fashion from the mitral clip to surgery. 3/4 of participants had primary mitral regurgitation, that is, a valve leaflet problem. And the outcomes of the trial suggested that the clip was somewhat less effective at reducing mitral regurgitation, but did in fact prove to be safer than surgery. And so the clip was approved for primary mitral regurgitation, but restricted to patients with severe MR at high risk for surgery. Because remember, surgical repair is definitive for this condition. Of note, candidates for the clip cannot have severe leaflet calcification because the clip, which only comes in one size, cannot squeeze together the valve leaflets if they're thickened and very calcified. Now, with that overview of primary mitral regurgitation, let's turn our attention to secondary MR, which, as I said before, is a ventricular problem. There are two primary forms of secondary mitral regurgitation that are a problem of the ventricle. One is an ischemic cardiomyopathy when there can be typically tethering of the posterior leaflet, or a non-ischemic dilated cardiomyopathy where both papillary muscles and in turn the mitral apparatus is pulled apart because of the enlarging left ventricle, which leads to central malcoaptation and a large central jet of mitral regurgitation. Now, with a failing ventricle, that increased filling and workload from the incessant MR can further impair and strain a ventricle that's already struggling to begin with. That's reflected in these data that show the prognostic implications for secondary mitral regurgitation in systolic heart failure. If we stratify patients in green without secondary mitral regurgitation, in blue those with mild to moderate secondary MR, and in orange those with severe secondary MR, you can see that survival free from heart failure hospitalization is dramatically lower in severe functional mitral regurgitation. And overall survival is reduced in patients with severe MR whether there is an ischemic or non-ischemic cardiomyopathy. Severe functional or secondary mitral regurgitation is a marker of high mortality in patients with cardiomyopathy. So how do we diagnose and follow up secondary mitral regurgitation? Well, again, the guidelines tell us that transthoracic echo is important to establish the etiology and extent of the MR, as well as to assess the left heart function in the face of the regurgitant lesion. Importantly, it can also estimate the severity of pulmonary hypertension, a consequence, as I alluded to, of chronic elevation in left atrial pressure. Non-invasive imaging, cardiac CT or catheterization is important to establish the etiology of secondary MR, that is, to distinguish an ischemic from non-ischemic cause, as well as to assess myocardial viability, which can influence management. Medical therapy is recommended, as it is for all patients with systolic heart failure, when there's mitral regurgitation and a reduced ejection fraction. ACE inhibitors, ARBs, angiotensin receptor neprilysin inhibitors, beta blockers, aldosterone antagonists are indicated. And again, non-invasive imaging is important to establish that viability and the etiology of the mitral regurgitation. Now, until recently, there's been a lot of controversy about whether to repair or replace the mitral valve in secondary ischemic mitral regurgitation. The Cardiothoracic Surgical Network did a trial of 251 patients with severe ischemic mitral regurgitation and randomized them in a one-to-one fashion to either chordal-sparing replacement or a downsized annuloplasty repair to tighten up the annulus and reduce the size of the mitral orifice. In this case, there was 2-year follow-up with a primary outcome of mortality. And across those 2 years, there was no significant difference in the rate of death in mitral valve replacement or repair. Early on, the curves separate, but across the 2-year follow-up, no statistical difference. However, mitral regurgitation recurred more frequently in the repair group, resulting in more heart failure-related adverse events and cardiovascular admissions. That's illustrated in this bar graph, where repair is on the left and replacement is on the right. And recurrent MR is in the dark green. You see it's dramatically greater in the repair than replacement group. Rates of death not preceded by recurrent MR are numerically higher in the replacement group compared to repair. And then the death preceded by recurrent MR or reintervention appears to be a little bit higher in the repair group. And so what do we do to intervene on patients with chronic severe secondary mitral regurgitation? Well, there aren't any class 1 recommendations. However, we have 2A recommendations that mitral valve surgery is reasonable with chronic severe MR in patients undergoing another surgery like a CABG or aortic valve replacement, and that it's reasonable to choose a cord-sparing replacement in favor of an annuloplasty ring if the operation is considered for severely symptomatic patients who have persistent heart failure despite guideline-directed therapies. Mitral valve surgery in a Class 2B recommendation can even be considered for severely symptomatic patients with chronic severe secondary MR with symptoms, or again, in those with moderate ischemic MR, so stage B valve disease, undergoing another cardiac surgery, but with a less intense class of recommendation. The solution to treating mitral regurgitation with cardiomyopathy is in treating the cardiomyopathy optimally, typically with medicines and devices before turning our attention to mitral valve surgeries. In part because of the surgical risks in patients with heart failure, there has been expanding interest in percutaneous options, including MitraClip and other novel devices to treat mitral regurgitation in patients with heart failure and reduced ventricular function. These are data from the Everest-2 trial at 1 and 4 years that separates patients according to primary and secondary causes of MR, and in turn looks at the relative benefit of the MitraClip versus surgical intervention. In those patients who have primary MR, so a valve leaflet problem, it looks like surgery was better in the Everest-2 trial. However, in those patients with secondary mitral regurgitation, there was no difference between the clip and surgery. But importantly, there was a positive p-value for interaction, highlighting the fact that there can be therapeutic differences in primary versus secondary MR that justifies the elucidation of whether it's a valve problem or a ventricular problem leading to the regurgitation in the first place. This single flow diagram summarizes the indications for surgery in mitral regurgitation. Again, in primary MR, from prolapse, rheumatic disease, or endocarditis, if there's severe symptomatic or asymptomatic mitral regurgitation, we proceed with intervention in symptomatic patients provided the EF is more than 30%. If it's not more than 30%, surgery is much riskier and so does not have a high level of recommendation. In asymptomatic patients, if there's evidence of ventricular compromise with a reduction in EF below 60% or an enlargement of the ventricle, that is stage C2 valvular disease, then surgery also has a class 1 recommendation. It can occasionally be considered if there's an increase in LV size or new onset atrial fibrillation, provided that the likelihood of repair is high. If there's stage B disease, we typically use periodic monitoring based on the nature of the valve disease and the size and function of the ventricle. Now, for secondary mitral regurgitation, we treat the coronary disease, we treat the systolic heart failure with guideline-directed medical and device therapy. And for those patients who remain symptomatic with persistent symptoms, then we can sometimes consider surgery, even for isolated secondary mitral regurgitation. With that summary of mitral regurgitation behind us, let's now move on to mitral valve stenosis. Now, the leading cause of mitral valve stenosis worldwide by far is rheumatic valve disease. Now, rheumatic valve disease can affect any of the heart valves and is a consequence of rheumatic fever. Rheumatic fever leads to valve inflammation and thickening, fusion of the commissures of the valve and the valve leaflets, and calcification that leads, in this case of the mitral valve, to a fish mouth appearance of the valve. This is a pathologic specimen of the left atria pulled back, looking down on the top of the mitral valve leaflets with its very small orifice. Group A streptococcal infection recognition and treatment lowers the incidence of rheumatic fever and in turn reduces the risk of rheumatic valve disease. Now, rheumatic valve disease can affect patients up to 1 or 2 decades after the initial rheumatic fever. And when rheumatic valve disease is present, pure mitral stenosis is present 28% of the time, mixed mitral valve disease with both stenosis and regurgitation 40% of the time, and around 28% of the time there's mixed valve disease with the mitral and non-mitral valve, such as aortic regurgitation or aortic stenosis. And interestingly, 2/3 of the folks who suffer from rheumatic heart disease are women, suggesting that there's some immune-related phenomenon with sex and post-strep complications. These are data from worldwide health programs looking at the evolving prevalence of rheumatic valve disease over the last 25 years. The color code illustrates the change in standardized prevalence of rheumatic heart disease. Those countries in green or light green to yellow have had a decrease in the prevalence of rheumatic heart disease, whereas those in orange or red have actually seen a rise in the prevalence of rheumatic heart disease. And the number of prevalent cases are represented by the size of the circles. You can see that it is most prevalent in sub-Saharan Africa, the Middle East, South, and Southeast Asia. It is relatively rare in North America, Europe, and South America. Now, the physiology of mitral stenosis is important to understand because it impacts clinical management. The normal mitral valve orifice is between 4 and 6 square centimeters, and mitral valve stenosis is present when it's reduced to less than 2 centimeters squared. That reduction in orifice leads to an increased gradient of pressure as blood flows from the high pressure left atrium and diastole into the left ventricle. And that marked elevation in left atrial pressure can lead to atrial enlargement, which in turn can lead to atrial fibrillation and thrombus, pulmonary hypertension, and in extreme cases, even hemoptysis because of rupture of the pulmonary vasculature. That back pressure is transmitted through the pulmonary vasculature into the right heart and can eventually lead to right heart failure. This is an illustration on the right of the pressure curves within the wedge tracing, the left ventricle, and the aorta. You will note that in the diastolic filling period, the left ventricular diastolic pressure and the pressure in the wedge tracing is identical. That's because there is no gradient between the left atrium and the left ventricle during most of diastole. In contrast, there's a dramatic gradient between the pulmonary capillary wedge pressure and the left ventricle in mitral stenosis. And because of that high gradient of pressure, it takes more time for blood to fill the left heart in diastole. So the heart likes it when the rate is slower in mitral stenosis, whereas clinical compromise can arise with tachycardias. And indeed, the precipitant and recognition of mitral stenosis is often accompanied by a condition that leads to tachycardia, such as appropriate tachycardia in the case of fever or anemia, or the tachycardia that arises in hyperthyroidism, pregnancy, or even atrial fibrillation. The clinical exam is very important in the recognition of mitral stenosis. Cardiovascular findings include an accentuated delayed S2, which is mitral valve closure, an early diastolic opening snap after S2, a low-pitched diastolic rumble that can be accentuated in exercise, and the diastolic murmur of stenosis is best appreciated in the left lateral decubitus position at end expiration with the bell rather than the diaphragm of the stethoscope. There can be a loud P2 signifying pulmonary hypertension, or even an irregular pulse with atrial fibrillation. Extracardiac findings include pulmonary rales or peripheral edema, ascites from right heart failure, pinched facies or a malar flush, which is seen in rheumatic mitral stenosis, as well as hoarseness from massive left atrial enlargement leading to recurrent laryngeal nerve palsy, which in mitral stenosis is called Ortner's syndrome. Now, it's important to note that a diastolic murmur can be present in conditions other than mitral stenosis, including severe MR because of the large flow of blood in diastole back from the left atrium into the left ventricle, and aortic regurgitation from an Austin Flint murmur, where the regurgitant aortic jet abuts the opening of the anterior mitral valve leaflet, as well as an atrial myxoma, which can functionally lead to a gradient between the left atrium and the left ventricle, much like mitral stenosis. Echocardiography is similarly critically important for the evaluation of the patient with suspected mitral stenosis, both to determine the severity of mitral stenosis, but also the etiology, whether it's rheumatic, calcific, or functional stenosis from something like a myxoma. This is a typical echo in rheumatic heart disease with an anterior leaflet that looks a little bit like a hockey stick. Similarly, a retracted posterior leaflet that does not open fully. You can see that the left atrium is already beginning to enlarge. If we use a short axis view across the mitral valve, this looks a lot like the fish mouth that I showed you on the anatomic specimen before. We can directly planimeter the area of the valve and determine if there's mitral stenosis. Now, severe mitral stenosis is defined by a valve area less than 1.5 square centimeters, or if you don't use planimetry, a diastolic pressure half-time more than 150 milliseconds. So it takes longer the more stenotic the valve is for blood to transit from the left atrium to the left ventricle. Very severe stenosis is when the valve area is less than 1 centimeter. The stages of mitral stenosis track with those of the other forms of valvular heart disease. Typically, there's doming of the valve in early rheumatic mitral stenosis. With progressive disease, there's commissural fusion, and the valve area begins to be smaller. Usually when there's evolving mitral stenosis, there's left atrial enlargement, but the pulmonary pressures are normal. At this stage, in that latent phase between rheumatic fever and the clinical presentation of valvular heart disease, there can be normal pulmonary pressures and no symptoms. Rheumatic valve changes continue with further thickening and commissural fusion, and planimetered areas less than 1.5 square centimeters. Echocardiography again defines the severity of stenosis And then when it becomes severe, patients typically have severe left atrial enlargement, often atrial fibrillation, and elevated pulmonary artery systolic pressures. Symptomatic patients almost universally have severe or very severe stenosis with elevated pressures and are at risk for atrial thrombosis with or without atrial arrhythmias. These patients have signs of both left and often right heart failure with decreased exercise tolerance and exertional dyspnea. These are the guideline recommendations for diagnosis and follow-up. For mitral stenosis, the Class 1 recommendations include regular echocardiography, particularly in rheumatic heart disease, to define if there are concomitant valvular heart lesions, and to demonstrate valve leaflet morphology so that we can determine suitability for different treatment options. If the transthoracic echo isn't clear enough, then transesophageal echo should be considered. And again, if there's a discrepancy between the resting Doppler echo findings and the clinical signs or symptoms, then exercise testing either with Doppler echocardiography or invasive hemodynamic assessment can be warranted. Medical therapy for mitral stenosis is recommended, particularly if there's mitral stenosis and atrial fibrillation, whether the atrial fib is permanent or coming and going. If there's mitral stenosis with a prior thrombotic event or mitral stenosis with an established left atrial thrombus, anticoagulation is indicated. And guidelines say that this anticoagulation should either be with a vitamin K antagonist like warfarin or with heparin and not with a direct oral anticoagulant. Heart rate control may also be beneficial in patients with atrial fibrillation and a rapid ventricular response, and it may even be considered in sinus rhythm and symptoms associated with exercise to reduce the slope of heart rate increase with exercise and allow greater time for diastolic filling. A treatment option that is unique for mitral stenosis is the percutaneous mitral balloon commissurotomy. It's indicated in symptomatic patients with severe stenosis, in carefully selected candidates with pliable leaflets without calcification. In those with heavily calcified leaflets, where you could crack open the valve and cause either a stroke from calcium transit or regurgitation, replacement is probably the better option. Balloon commissurotomy has been shown to double mitral valve area and reduce that atrioventricular pressure gradient while improving symptoms, with a good event-free survival and a moderate rate of restenosis, with a repeat procedure often needed within a decade or two. So to summarize the intervention for rheumatic mitral stenosis, when there's rheumatic mitral stenosis and severe or very severe stenosis, if patients are symptomatic and have a favorable leaflet morphology, they should undergo balloon commissurotomy. If they're symptomatic and have an unfavorable morphology with a lot of calcification and thickening, then replacement should be considered. In patients who have very severe stenosis, they should consider undergoing commissurotomy even if they are asymptomatic, provided that leaflet morphology will allow it. And then in patients with progressive mitral stenosis with valve areas that are not severely reduced, if there are symptoms and a rise in wedge pressure with exercise, there's a Class 2B recommendation for considering commissurotomy. For all other patients, periodic monitoring with echocardiography, clinical examination, and ECG to identify atrial fibrillation is warranted. What I'd like to leave you with in this review of mitral valve disease are the following take-home points. First, that guideline-directed therapy for mitral regurgitation requires a distinction between primary valvular and secondary ventricular causes of regurgitation. Primary MR is a valve problem, secondary MR is a disease of the ventricle. Mitral valve prolapse with severe MR is the leading cause of mitral valve surgery in North America, and mitral valve repair rather than replacement is the preferred treatment for severe primary mitral regurgitation, particularly when it's from prolapse. Secondary mitral regurgitation is an important prognostic marker in systolic heart failure. and that the leading cause of mitral stenosis is rheumatic heart disease worldwide, which is fortunately reducing in prevalence owing to group A streptococcal recognition and treatment. And in most patients with isolated rheumatic mitral stenosis, a percutaneous commissurotomy is the preferred treatment, provided there are pliable valve leaflets. Thank you for your attention, and now let's move on to some questions to test your knowledge about mitral valve disease. Question number 1. Which of the following statements about mitral valve prolapse is false? Is it heritable forms of prolapse include Marfan's and Ehlers-Danlos syndrome? Mitral valve prolapse affects 0.2% of the population. Mitral valve prolapse with severe mitral regurgitation is the leading indication for mitral valve surgery in North America. Mitral valve prolapse can present with acute severe mitral regurgitation due to chordal rupture. Mitral valve prolapse can be associated with migraine, headaches, and atypical chest pain. Which of the statements is false? Well, the false statement is that mitral valve prolapse affects 0.2% of the population. In fact, mitral valve prolapse is extremely common and estimated to affect 2.4% of the population, based on screening echocardiography in an unselected general population. Mitral valve prolapse often results from connective tissue disorders that lead to abnormal collagen formation. It can be heritable, as in Marfan and Ehlers-Danlos syndrome, and can be familial even without a syndromic presentation. As such, screening of first-degree relatives of patients with mitral valve prolapse with an echo is indicated. Prolapse leading to MR is the leading cause of mitral valve surgery in North America. In contrast, in the developing world, rheumatic valve disease is a predominant cause of mitral regurgitation that requires surgery, usually with mixed mitral stenosis and regurgitation. Prolapse can present with either chronic severe MR or acute severe MR due to chordal rupture, and the syndrome can be associated with other symptoms like palpitations, chest pain, or migraines. Question number 2. A 65-year-old man with a history of anterior MI who had primary PCI to the left anterior descending artery 2 years ago presents with progressive exertional dyspnea. He gets out of breath hiking and jogging. His blood pressure is 120/72, mild elevation in the jugular venous pressure, but clear lungs with a laterally displaced point of maximal impulse and a 2 out of 6 holosystolic murmur and an S3 gallop. ECG reveals sinus rhythm at 60 and a typical left bundle branch block with a QRS duration of 160 milliseconds. Echo shows an EF of 30% with severe functional mitral regurgitation. Angiography confirms a patent LAD stent and no new stenoses. He's on great medical therapy with lisinopril, metoprolol, and spironolactone. What is the most appropriate next step in treatment? Is it referral for chordal sparing valve replacement? Referral for a ventricular assist device? Referral for cardiac resynchronization therapy? To initiate ivabradine? Or to refer for restrictive mitral annuloplasty? Well, the most appropriate next step in treatment is to refer for cardiac resynchronization therapy. This patient has secondary mitral regurgitation due to an ischemic cardiomyopathy. It is a disease of the left ventricle. In essence, he simply has systolic heart failure. He has class 2 functional limitation with symptoms with moderately heavy exertion and is already on excellent guideline-directed medical therapy. We know that severe secondary mitral regurgitation in heart failure is a marker of adverse prognosis and should be treated first and foremost with optimal medical and electrical therapies. Because the patient is in sinus rhythm with a wide typical left bundle branch block and low ejection fraction, he is an appropriate candidate for consideration of cardiac resynchronization therapy. Valve surgery should only be considered if he's symptomatic after guideline-directed medical therapy with class 3 or 4 limitation. And if he's severely symptomatic, which he is not now, then transplant or LVAD could be considered. Ivabradine is not indicated unless the heart rate's in sinus above 80, and certainly the patient's too well at present for a ventricular assist device. The final question is that of a 33-year-old female who presents to the emergency room at 25 weeks gestation with progressive dyspnea, now at rest. She also has orthopnea and fatigue. She's never had any prior medical problems. Physical exam is notable for an opening snap after the S2, a 1 out of 4 diastolic murmur heard best in the left lateral decubitus position. She is tachycardic at 108 beats per minute, normotensive. She receives oxygen, diuretics, and diltiazem. And echocardiography demonstrates a severely reduced mitral valve area at 0.5 centimeters squared with non-calcified pliable leaflets and normal left heart function. Which is the best approach for management? To start carvedilol, to start lisinopril, perform percutaneous balloon commissurotomy, to recommend immediate cesarean section, or to start digoxin? Well, the best approach for management is percutaneous balloon commissurotomy. This patient has severe symptomatic mitral stenosis. The most likely etiology is rheumatic heart disease, a sequelae of rheumatic fever that remains the leading cause of mitral stenosis. The likely precipitant in this case is pregnancy, given its association with plasma volume expansion and increased heart rate, which in turn worsens the left atria to ventricular pressure gradient. In pregnant patients with severe mitral stenosis and class 3 or 4 functional limitation, like this patient, percutaneous mitral balloon commissurotomy is indicated prior to delivery. Emergency cesarean section is not indicated, particularly because the fetus is only at 25 weeks and there is an acceptable treatment option for the mother. Judicious use of diuretics and beta blockers can be considered in milder forms of mitral stenosis in pregnancy, but in pregnancy, ACE inhibitors should be avoided because they're teratogenic. Digoxin is only indicated for rate control and atrial fibrillation, and since this patient's in sinus tachycardia, given the regular heart rate on exam, digoxin is not indicated.